testosterone for sickle cell disease with a testosteronologist named Omar Hajmousa, who's a PharmD. Omar, thank you so much for being with us today and bringing us this incredible information.
Thanks for having me, Doc. I'm really excited to do this.
This is going to be really important. Now, everyone in the world, sickle cell anemia, sickle cell disease, there is the disease that's quite uncommon, but it's common, or it's something that we know people have, but it's quite rare. And we're going to go into the public health information here with Omar. Yeah, and there's about 10% of African Americans and other people in America that have the carrying state. And when I was looking at my ABCDs, and then you have D, and you have the hemoglobin and the androgen-induced erythrocytosis, and all the red blood cell stuff for all the men that are on testosterone, and then working with Omar and these brilliant testosteronologists that are coming in to spread the word of testosterone and proper use of androgens in the world, Omar brought to my attention, Doc, this is something cool. Like, I know that we have some gene defects with the hemoglobin that have mutated over thousands of years, tens and thousands, hereditary hemochromatosis, thalassemias. There's many types of thalassemias. I see it in my day job. It affects men. It's a huge effect when you look at the iron metabolism. And then there's hereditary hemochromatosis versus sickle cell. I say it all the time. And Omar brought to my attention that, Doc, why wouldn't they use these men and women suffer? It's equally men and women, and he's going to go into the science on this. But we thought, and we did research together. I wanted to do a video on this. So today is our presentation on the aspects of, can testosterone help those that are suffering with real sickle cell disease? I've seen it in New York and Connecticut when I was a doctor. There's a painful crisis, and it's so sad. And I want to help everyone I can. And androgens can be repurposed. Once again, are we missing something? Omar, tell us about sickle cell.
Okay, let's take it away, Doc. So we have 100,000 Americans that are affected by sickle cell disease and 3.2 million people worldwide, people that can be helped. There's an estimated 1 to 3 million people that have sickle cell trait, so they're carriers but don't have the disease, and that's something we'll discuss. And it's very important to know that it's most common in people of African, Mediterranean, Central, South American, and South Asian descent. Mm-hmm. And it is also the most common inherited blood disorder in the USA. So it's a very important disease, and it is sometimes underrepresented and undertreated. It is an autosomal recessive genetic disorder, which means it affects men and women equally. It means that you have to have both copies of the recessive gene for the disease to present. And it is a mutation in an amino acid inside the blood cells. Mm-hmm. Through a nationwide cohort of Medicare and Medicaid beneficiaries, they looked at 94,616 individuals, so a lot of people. And between 2008 and 2016, and it showed that life expectancy of those patients is 52.6 years compared to the general Black population, which was 75 years. So they're dying early, they're suffering, and if there's anything we could do to help, that would be very important to do.
Wow. What about the natural progression of hypogonadism for these men in puberty? And tell us about that. What happens and what's the mechanism on that? They have low T.
Yeah, and at a higher frequency compared to a regular general population. So it develops in about a quarter of the men with sickle cell disease compared to 6 to 12% in general population. And it develops in adolescents and young males compared to middle-aged and older men in sickle cell disease or non-sickle cell.
Adolescents. Yeah. Wow. What else? What else? Tell us about sickle cell, that painful crisis. That's such a horrible thing.
Yeah. It really is, and it is caused by the blood flow being blocked, because the cell sickle, which causes them to clump up and stick to the walls of the blood vessels, which also blocks it blocks blood flow, leading to painful crises. And there are about 30 to 40% of adolescent and adults suffer from chronic pain because of that.
Wow.
And what we know about opioids, and some of them are managed with non-pharmacology, non-opioid, and chronic opioid therapy. But what we know about opioids is they can affect testosterone. Is that correct, Doc?
Yes. Yeah. So this is the unknown synergy. This is the unknown cumulative effect when you understand the medical aspects of how the moons line up for someone, where they have an underlying organic disease like sickle cell, real sickle cell disease, not trait, not the carrying state. They have the real disease and they're suffering. And then because of the therapeutic interventions, potentially because we have to treat them for pain, we use opioids. And I've seen that. And I'm not an expert in sickle cell. I'm an internal medicine doctor, but I've seen it. And there's no criticism on the doctors that are pain doctors. They have to use these people are suffering until we have the gene therapeutics. And again, who's going to pay for this and what's the availability? Look at the numbers. So when you have another inherent disease state called hypogonadism. So these men, again, and my heart goes out to the women that are suffering with this too. But for today's presentation, we identify that there's equal men and women that are suffering from this. We do identify, and we don't disparage that. But we'd like to look at the specific utility of testosterone for this subset of men, even in puberty, that are hypogonadal, and from the utility of the medications that are used for treating pain, opioids. Everyone go to Google, put in, can opioids lead to low testosterone? Put the jaw strap on. And again, doctors need to understand testosteronology. It's not just winging it. Low T, let's just check what it is. Maybe it's a fat guy with diabetes. No, it's a day job for diagnosis and for management. And that's why I'm here today with these excellent academics and doctors. Like, the future of America is not with doctors, it's nurse practitioners, mid-level practitioners that are specified, including PharmDs. Right there, right here, a young man right here, super educated. Ohio State, right?
Yeah, and just won the national championship last night. So it's a great day to be a Buckeye.
Dude, I saw it.
Yeah.
But it's not Ohio State. It's the Ohio State. Forgive me. So unbelievable. Super congratulations. Back to at hand here. So we have low T at such a young age. Doctors don't understand testosterone. Tell us the data. Where's the research? Have the academic communities looked at treating sickle cell patients with testosterone? Give us the whole breakdown.
Yeah, Doc. There's very minimal research on this, and we'll talk more about this because you're going to love the doses that you're going to see in the next few studies that we present. But there have been one where they tested using testosterone and the hematological response to testosterone. They tried, spoiler alert, oxymethylone, which, to those of you that don't know, that's Anadrol. So that'll be a very interesting one to look at. And they have also looked at testosterone endogenate injections, and there's one on clomiphene, since that's becoming more of a nuisance now, especially in younger men. So let's start with our testosterone one. They looked at 11 patients with sickle cell disease, ages 9 to 36 years, 4 men, 7 females. All the men had experienced Priapism before, which we'll talk about what that is and where that risk is, and how this study is the one that made practitioners less likely to prescribe it because of the fear of Priapism. They gave either testosterone cypionate or enanthate IM every week. And this was in 1970. They knew to give it every week.
Wow.
Which is very
Not
funny
every
compared
2
to now.
weeks.
Yeah. Not every 2 weeks. Not every 4 weeks.
Doctors, pay attention.
Yeah. Every week. But what's funny is for females, the mean dose was 285 milligrams a week.
What?
Yeah.
Say it again.
285. Yeah.
How old were they?
The range was, there was a 9-year-old female who got
Come on!
200 milligrams for 3 weeks. 200 milligrams a week for 3 weeks. I had to read it multiple times to make sure this is correct. Yeah.
I have to hear it multiple times. Yeah. Let's keep going.
And then for men, the mean dose was 675 milligrams a week, which...
What?
I guess they put them on a cycle, Doc. Yeah.
That's a big... I almost benched 600 pounds, and I didn't take that much.
Yep. But that study resulted in 33% increase in hemoglobin, 39 in hematocrit, minimal change in red blood cell lifespan. Some of the patients had increases in lifespan, others had decreases, others had no changes. And then there was no change in sickling tendencies after the first 4 weeks. But every patient had priapism. Every male patient had priapism. Wow. Which, again, ridiculously high doses.
Milligrams of testosterone causes priapism, probably in the average bear.
Yeah. And that study concluded that androgens at pharmacological doses, and that's what they said, increased red blood cell mass in patients with sickle cell anemia and increased hemoglobin hematocrit. And,
absolutely ridiculous. Absolutely brilliant for you to bring this up, and absolutely flawed and embarrassment. And that's where the train ran off the rails.
Yep. And Doc, this shows how well we've progressed in the medical community. This was in 1970, and I don't think we'll ever repeat that again.
Right.
But another very important conclusion is they didn't find any effects on frequency of crisis, so no increase or no decrease. But very small number of patients, and the patients have had infrequent crises before the treatment. So it's very hard to say that because of giving that much androgen, it's not affecting it.
It's like saying let's give people a full bottle of vodka every day, and versus a one shot of vodka, and see if it has any effect on cardiovascular outcome. I mean, it's embarrassment. That's an embarrassment. Yeah. So that's okay. What else we got? The doctors didn't know. They had no clue.
Yeah.
Right.
The other one where I don't think they had a clue either was using oxymethylone, which is Anadrol, in 1975. Looked at 7 patients. They all had sickle cell anemia. The ages were 14 to 48 in the range. 5 males, 2 females. They were given oxymethylone at doses of 40 milligram per square meter for females. The average dose was 63 milligrams a day, Doc.
A-bombs. These are called A-bombs. Go to Google, put in steroids and A-bombs. I benched the most I've ever benched with testosterone and one Anadrol a day for just 2 weeks. I mean, I'm not kidding. I am not kidding. This is more, it's just more unbelievable. They have no clue of what the drugs, what the purpose of the do. But boy, I tell you, what were the outcomes in that one?
Well, for men, get ready for it. They gave 268 milligrams a day on average.
Ooh.
Yeah. So the 63 was for women.
It's unreal.
But they did conclude that androgens they can be used to treat patients with sickle cell anemia.
Wow.
And we're talking about anemia here. Androgens should only be considered in patients with lower frequency of crises. They should be stopped after 3 months of therapy, even if significant improvement occurs. And we need to weigh the benefits of androgen therapy compared to hepatotoxicity, which is liver toxicity.
Right.
But it's oxymethylone. It does that. And there
I
was one
mean,
of the males whose bilirubin went from 5.5 milligram per deciliter to 52 milligram per deciliter and was stopped.
Anadrol 50, like Dianabol, is massively hepatotoxic.
Yeah.
And, we knew it then. And, Schwarzenegger knows it. Dianabol, right? But he took 10 milligrams a week. So
Yeah.
they
But
gave,
there
what did they
was
give
red blood.
girls?
Oh,
That
sorry.
was,
Yeah.
so hold on. So Arnold took 10 milligrams a week of Dianabol, wink, wink, he says, which is we know is not true. And how much do they give the girls of Anadrol?
60. Let me go back to that. It was 63 on
Yeah,
average. 63
Dianabol
milligrams. Yeah.
and Anadrol are very similar, but there are differences. But it's an outrageous. It's just a, they didn't have crack back then, but we would say like you're smoking crack pipe stuff. It's just an outrageous mistake and scientific,
Yeah.
ethical error, flaw that you would give that to anyone. Again, we're still looking at testosterone. Let's keep going. What else we got?
But it is something that they noticed in this study that was very important is, of course, red blood cell mass increased, hematocrit increased, which you're giving them that much anadrol, it's going to happen. And they did see a larger number of red blood cells susceptible to sickling in all patients, but there was no increase in frequency of crises,
Wow.
and there was no priapism reported. But
With
at these
Anadrol.
doses, yeah.
With Anadrol. This is where we need a lot more research, and we're going to do it, right? We're going to get into this. So, all right, let's keep going. What else we got?
And this is one where they kind of overcorrected slightly, but still somewhat pharmacological dosing feels a bit more closer to home. They tried to look at testosterone and priapism because of the past studies that showed that priapism will happen. So they did a 12-month safety report that could also double as a phase 1 clinical trial on 7 men at the University of West Indies in Jamaica. And they were given testosterone decanate IM, 1 gram, and then 1 gram after 6 weeks, then every 3 months for 12 months total, which is generally the dosing that you see.
Yeah.
But
Yeah.
we'll talk about how testosterone decanate isn't an ideal choice for this. After the 12 months of therapy, they had, out of the 5 patients, 1 patient unfortunately passed due to acute chest syndrome, a complication of sickle cell. One of the patients abandoned treatment because they wanted to become fertile and have children. But what they saw was total T increased, but not by that much. So the median was 306 nanogram per deciliters, went up to 323 nanograms per deciliter. But what's important is those men had significant improvement in sexual function on the questionnaire scores, and they had improvement in the androgen deficiency questionnaire results, and there was no change in the quality of life on the questionnaire result. No significant changes between 6 and 12 months. There was no increase in priapism episodes, and
Wow.
yeah, and the main side effect was injection site pain, that's something that you'll see with any of these.
Nothing. Yeah, it's nothing.
Yeah, and no increase in crises or hypersensitivity or edema.
Wow.
So they concluded that TRT can be safe in hypogonadal men with sickle cell disease. It does not increase the number of priapism episodes and offers a therapeutic benefit in men.
And this is undecanate. So explain to us undecanate versus enanthate or cypionate or Sustanon 250 that we would use today.
Yeah. So these are all what they call esters of testosterone, and it's just how the testosterone is put in the medication, the ester that's attached to it. That impacts the half-life of the medication. The half-life is how long it takes for your body to get rid of half the drug that's been given. When we're looking at enanthate, if I remember correctly, about 4 to 5 days for the half-life. When we're looking at propionate, about 2 to 3-ish. Cypionate is about 7 to 8. And decanate has a very long half-life of about 3 months. So it is very slow acting, takes very long to build up in your system, and takes very long to leave.
Right. I think some of the half-life for undecanate might be a little less, but again, you're right on point. And the half-life, those are just half-lives in the initial evaluate the initial FDA, if you will, science evaluation. When you look at half-lives, it's based on the fingerprint of the damn enzyme of the man or the woman.
100%. Yeah.
I mean, so there's a huge, that's why in the pharmacology world, we're not going to do it, but we can go to deep dives of the pharmacokinetics and the peak of concentration and the real functional half-lives, and how that's why we microdose, right? Yeah. So microdosing, for those of you who don't know, that's the only way to really provide is sustainable, including frequency of injections have to be taken in consideration. Who wants to be a pincushion? Yeah, right. You should put testosterone into an insulin delivery mechanism and just put it into your side. I've thought about it, and it could just pump like insulin's pumped regularly, basal insulin. Well, you could do the same thing with a pump with testosterone, but is it worth it? And guys will mimic that by giving small injections every day. The regular doctors, unfortunately, it's an embarrassment for them that they give a good endocrinology doctor. Not all, not everyone. I understand that, especially the young guys. But if you talk to anyone in this world, testosterone, which is well above ground now and needed, a lot of doctors just give that Cypionate or Nanthate or Sustanon 250 1 milliliter every 2 weeks, or 2 milliliters in the rear end every month. And that was what they did based on the FDA. And that's, you give it once every 2 weeks. And imagine it goes way up and way down. And it's just a no-brainer that men feel like shit. And not to mention the estrogen conversion, the moodiness, you're up, you're down. So we have to microdose. Again, and if someone wants to take that idea and get a patent on it, you better give me a little money. I'm just kidding. So, I mean, come on. So no one's going to do it because microdosing is easy to do. Probably even once a week is good enough. Like I do it 35 years now, or more than 35 years, technically, including my history of early steroid use when I was 23. I'm 60, and therefore I was shut down. And by the time I was like, I don't know, 28, 27, I've been basically on testosterone ever since. Okay, so I live, sleep, eat, and poop this stuff. So the reality really is you need to keep the levels, not these ridiculous high levels. And Anadrol is not tier. Anadrol, Dianabol, and Proviron and all these things, it's not, they're good add-ons, and Masteron and Primobolan, that's a whole other animal. But for sickle cell guys, what should we do? So how do we wrap this thing up? So what do you think we could do? Because again, we're giving ideas for studies. Anyone who really wants to do a study and you have some horsepower in the academic world, reach out to us.
And Omar, that's my biggest conclusion, is we owe it to these men to give them good research and give them something that they can use, not 675 milligrams of testosterone, not Anadrol, not testosterone decanate, something that is standard of care, right, and seeing exactly what it does, with the blessing of a good hematologist and adherence to their medications that they need.
So what should we do, Omar? What should we, let's end with a reach out, with a shout out. What are we looking for? What are we looking, because we want to do a study on this, don't we?
Yeah, for sure. And yeah, I wish somebody would be willing to do a study on this and follow that protocol. Like, reach out to somebody who does this for a living and knows how to treat hypogonadism, and then team up with a good hematologist, and let's see if these patients benefit from it.
So
it's not a contraindication to testosterone to use. It's not contraindicated in sickle cell disease. So even having a good hematologist on board, making sure you take your medications and you're adherent to them, I think it would be potentially beneficial to try to add testosterone to help with the hypogonadism and the symptoms.
Well, the last study that was done in the islands down there with those guys with the undecanate, they didn't have an increase in events. They didn't have sickles. They didn't have sickle cell events, right?
Yeah, and they felt better. Their levels didn't increase by a lot. But it's less than ideal dose to begin with.
Undecanate is the wrong drug. Yeah. Undecanate's the wrong drug. So again, we're giving this away for a secret. It's the wrong drug. I would like to not even entertain, because I own Testosteronology, And we have a lot of horsepower and resources in the world now, and every day gaining more for the goodness of people to utilize androgens properly. I would work with an expert researcher, and I would use my resources in my channel to enroll thousands, if they want, of sickle cell men all over the world into our trial. Thousands, not just 4 or 7. That's right there. That's not a. We're not going to disparage these prior researchers because we're standing on the shoulders of all the giants, even though we did make a good fun of them because they were giving Anadrol and 600 milligrams, just outrageous numbers, but they had no idea.
Yeah.
It's 1970. That was 50 something years ago. Now we know what's going on, and you could utilize truly physiologic, proper androgen regimen, which only we know, the testosteronologists, only we know what that really is, and understand all the other aspects from cosmetic hair loss and gynecomastia, acne in these men, not to mention young men and possible adolescents. Because I'm an adult medical specialist. We'd have to get a blessing from pediatrics because we do things properly. We'd have to endocrine pediatrics potentially because I'm an adult medical expert. So 18, 21. And then, of course, there's the function that if they start the androgen, even at any age, whatever androgen production they're going to have is going to be shut down for after a year or so. They're going to be those guys that were put on the undecanoate. I wonder where they are now. After a year of being exposed to androgens, there's a condition called anabolic steroid-induced hypogonadism, even though this is not anabolic steroid level, but it's going to shut down the hypothalamus pituitary gonadal axis. Oh yeah, to some degree, and they may not come back. And that's it. When we run this through the ethics board, when we run this through the board, we have to disclose that.
Yeah.
That's
and
why.
Also, do they want to have kids in the future? That's something that's very important to think about. Yeah, because if we're talking about young men.
So, and the heart issue is potentially, there's no free lunch. All this testosterone going around, it's great to see there's some accessibility and awareness of it, but it's cringy and embarrassing when these testosterone clinics, and anti-aging is a wrong word. When you give testosterone and steroids together, does it anti-age you, or does it accelerate aging with the potential for vascular disease and blood clots? Because it's potentially going to happen. It's called fingerprint medicine. You can't just McDonald's. Everyone is going to, this study showed that it's perfectly perfect for guys with heart disease. Travers trial. They were all medicated to protect against heart disease. Look at the small print. I don't have a heart attack because I can't, because I'm on all the medicines to protect. That's a little detail that's being left out, for men on androgens, women too. All right. So how do we wrap up with this, my dear Omar?
Just like we talked about before, very important to, these are men that we need to take care of and hopefully help feel better. No free lunch. Definitely need to make sure a hematologist is on board and taking care of these patients and getting their blessing before anything gets started. But I think it could be beneficial for them in the future, and making sure that they get the dose that's correct for them, the drug that's good for them, the duration that's good for them, versus just putting everybody on 200 a week HCG and an estradiol. Doesn't work for everybody. Spoiler alert.
Right. So if you're a man in the world, and potentially a woman too, but for men, it's a brotherhood for me. And I just felt like I found my brothers all across the world, and we're all an underserved group of men because we're men. And I found that to be really a beautiful thing among the whole world. Brings all of us together, every race, every nationality, creed, religion. We're just men. Forgive me, everyone else. So if you're a man and you have sickle cell, boy, take matters into your own hands responsibly, of course, with your doctors. Check to see if you have low T, and if you're suffering from the signs and symptoms of low T, which could be lethargy, brain fog, problems obviously with sex and fatigue, and not to mention if you're anemic. These medicines were developed to treat anemia. That's where we thought of this. And now, is it going to increase the sickling and the pathology, not to mention the priapism? Pay attention. Those are the questions. We don't have answers, and it looks actually, if you look at just the studies that have been done, it looks like it's okay if you use the proper medicine, which is not Anadrol and not a high dose of testosterone. Wow.
Correct. Yeah.
If we look at that study, and if I'm making the decision on this, looks like a green light to me to do more studies. Thank you so much.
Yeah.
Thank you so much.
With good standard of care. Yeah.
I hope this video gets out to everyone in the world. Please initiate beautiful comments. Please leave some of the hatred and some of the stupid comments for some other YouTube channel. We're doing the best we can. Guys like me and Omar. Thank you so much, everyone.